Good afternoon, or good end into the beginning of the morning. My name is Alphonse Pomp, and Ed Felix and I are co-moderators for this session. It's concurrent session SS09. We have a series of papers on sleeve gastrectomy, and the first presentation is a laparoscopic sleeve gastrectomy for obesity. Can it be considered a definitive procedure? The presenter is Chopra from the Jacobi Medical Center, Albert Einstein College of Medicine in New York. Dr. Chopra.
Thank you very much. Laparoscopic sleeve gastrectomy is establishing itself as an effective weight loss operation. At my last check, there are more than 40 studies in the literature talking about sleeve gastrectomy. There are short and medium-term data on weight loss and resolution comorbidities. This is where I work. I work north of Manhattan, and this is Jacobi Medical Center. It's next to Albert Einstein College of Medicine, to which we are affiliated. That's my disclosure. Sleeve gastrectomy is not a new procedure. It's actually an evolution of older gastroplasty procedures. Its origin is in the time when BPD was changed to BPD and DS, and sleeve gastrectomy was added. And then it has evolved through laparoscopic BPD DS with laparoscopic sleeve gastrectomy done by Michel Garnier for the first time. And Megan Strasse and Mill procedure actually gave further solidification to this procedure when we started resecting the stomach, and that improved the outcome of restrictive procedures. Now, background of the study, I work at Jacobi Medical Center, which provides services to indigent inner city population of the Bronx. And incidence of severe obesity and associated medical conditions is high in these poor communities, and access to bariatric care is limited. Follow-up is difficult due to socioeconomic factors. And so at that, in 2006, I thought sleeve gastrectomy could be a good operation with the low long-term morbidity. So we evaluated the effectiveness of sleeve gastrectomy in this patient population, weight loss in different weight classes and age groups, incidence of acid reflux symptoms, or resolution of acid reflux symptoms after sleeve gastrectomy, and incidence of weight regain or inadequate weight loss. Now, we have to define a definitive bariatric procedure. For a long time, until more recently, weight loss was the only criteria we were looking at when we said a procedure was successful. 15% to 25%, all the way up to 50%. These were in the 1980s. Then Barrow's score was designed with weight loss, resolution of comorbidities, and quality of life was included to define the success of the operation. So this is a retrospective review of our prospective database. We've done 260 patients over 4 years, and this is an analysis of 185 patients, consecutive patients with at least 6 months follow-up. This is the patient demographics. There were 11 conversions from sleeve to gastric bypass, leaving 174 patients for outcome analysis in the terms of weight loss and resolution comorbidities. 85% were female and 15% males. Super obese patients constituted about 37%, and length of follow-up is 6 to 36 months, and age is 40 years, average BMI is 49. And the complications, we had 26 complications, out of which 4 were leaks, 4 obstructions, and 4 bleedings. Leaks were all in the proximal part of the sleeve, and 2 were managed operatively, 1 was managed with a stent, and 1 was managed non-operatively. Bleeding was all self-limiting, no operative intervention was needed. Obstructions were converted to gastric bypass. All the 3 obstructions out of 4 were at that level of incisura. 1 obstruction was in the proximal part of the sleeve. Now, out of 11 conversions, 4, as we said, were for obstructions, 6 were for refractory reflux symptoms, and 1 for inadequate weight loss. This is the typical port sites, ports, retractor, and this is the end of the procedure with a linear staple line with reinforcement strips. This is a specimen with 900 cc's of saline in it, and that's the post-op picture. And we see the percentage access weight loss was 55 to 59% over 3 years, from 12 to 36 months. And that shows you in the form of bar diagrams. Inadequate weight loss we saw in 6 patients who lost less than 25% excess body weight. 13 patients regained an average of 13 pounds, which varies from 3 to 29 pounds. I'm sure with more time, more patients will regain some more weight. We've had 3 recent studies where we have got data on 5 to 6 years. And weight loss has been reported between 53 to 55%. And they have shown a weight regain of about 20% in about 20% of the patients. But the Barrow scores still remain good to excellent. Comparison with gastric bypass, which is a gold standard operation for morbid obesity, weight regain has also been reported in gastric bypass in up to 50% of the time. So sleeve results still compare favorably with these data. Now we try to tease out the weight loss difference between BMI less than 50 and more than 50, and we saw that patients who had BMI less than 50 lost at least 8 to 10% more weight loss as compared to patients who were more BMI with more than 50. And this was controlled for age. And this is the same thing shown in bars. And then weight loss based on age, we saw that younger patients less than 40 years lost more weight than patients who were more than 40 years. Again, the initial BMI was equivalent in both the groups. Resolution of comorbidities, we looked at hypertension, diabetes, asthma, sleep apnea, and GERD symptoms. We see that in about 50% of patients, hypertension resolved or improved. In about 84% of patients, diabetes improved or resolved. Asthma and sleep apnea resolved in 90%, resolved or improved in 90%. GERD symptom, surprisingly, actually improved in 11 out of 24 patients. So there is a recent systematic review of literature on sleeve with diabetes, which shows resolution in 66% and improvement in 26%. Our study had lower remission rate. That could be because of our patient population who never see a physician till they are sick, and they might have more severe diabetes. But overall results are comparable. Sleeve and acid reflux, 11 of our patients improved or resolved. 5 actually symptoms worsened. Additional 6 patients actually developed new onset of reflux symptoms. 4 from the new onset group and 2 from the worsened group were managed with conversion to a gastric bypass, and rest all patients were managed medically. How improvement happens after sleeve is still unclear in the literature. We really don't understand this as yet. It could be due to faster gastric emptying, as been shown in some studies. But on the other hand, how new reflux symptoms appear in some patients, it could be from a pre-existing or caused hypotensive low esophageal sphincter pressure, or it could be a relative narrowing at the lower part of the sleeve with dilated upper sleeve. In conclusion, we can say sleeve gastrectomy can be considered a definitive operation. Weight loss is satisfactory up to 6 years despite weight regain, which happens in all the other bariatric procedures. Weight loss is more in younger patients and those with lower BMI. Occurrence of acid reflux still remains a problem with this operation. Thank you.
Thank you. Thank you. We have the time for 1 or 2 questions. Please identify who you are and where you're from. At the mic, first question left.
Peter Gorek, New York. I was wondering how you're addressing small hiatal hernias. No doubt that large hiatal hernias should be fixed, but perhaps that small to moderate, did you tend to look for them and fix them?
Yeah.
Perhaps hoping to reduce the reflux, or you let the small hernias be?
Yeah, it's interesting you asked me this question because I go very aggressively looking for hiatal hernias. I think that is a major problem. A lot of my earlier patients, I was not doing it so aggressively. Even a small hiatal hernia with an intracrural dimple, I will mobilize the stomach completely from the hiatus. I have done anterior cruroplasty, sometimes I have done posterior cruroplasties, and get the whole stomach out of the hiatus.
One more question real quick.
Abderrahman Nimeri, Abu Dhabi. Thanks for a nice study. Do you counsel your patients differently now in terms of reflux? So if you have a patient who is morbidly obese and has reflux, do you do anything differently now?
Now, if a patient has a endoscopic evidence of severe esophagitis and has a really significant reflux, I will discuss with the patient that they might be better served with a gastric bypass. But this is definitely discussed. We should discuss acid reflux with all the patients who undergo a sleeve gastrectomy.
All right. I'm going to thank you very much.